Thanks, Doug, and thanks to Haag-Streit for putting this all together, and for Warren for coming up with this just absolutely brilliant idea. I'm going to be talking to you about my first year's experience with the Hill RBF calculator. And when I think about it, it's really supposed to be my experience, but as I give it a little bit of additional thought, it's really more of a journey than an experience. And the journey starts off, with, as any journey does, by first collecting data and analyzing that data, and there's always an emotional component to any journey. So I thought about it. When's the first word that I had of the RBF calculator? And I thought, and as things started to come clear to me, like most other iconic things, I don't remember when the first time was. But as long as I kind of understand the general concepts, then I feel pretty good about it. In the Hill RBF method, the three major data points for me are that it evaluates the data set, and it uses pattern recognition and artificial intelligence. Now, I don't really know much about artificial intelligence. Warren is brilliant, and he can figure this stuff out in his sleep. For me, it's a little bit harder. He actually confided in me one day that the underlying math makes his teeth hurt. Well, if it makes his teeth hurt, I would be completely edentulous with nothing. But we don't really need to know how a fuel injector works to know whether we're enjoying a ride from a fine car, and so I'm a devout pragmatist. So I just want to know that if it's data-driven and self-validating, continuously evolving, how does it work for me? And when I talk about my early experience, it really started with the beta test prospective study. This study was using criteria of patients that were undergoing elective cataract surgery with pretty much healthy eyes, front and back, normal topographies, and surgery that went beautifully. All of the patients had to meet the LensStar validation criteria, and there are several criteria, because the calculator is validated and developed for this instrumentation. And they all had to have inbounds calculations, as Dr. Hill has just educated us about. So the results were really pretty darn impressive. Of the 467 patients that we had in this prospective study, 91% were within the half a diopter target. And when we stratified by axial length, 98% of the axial myopes, longer than 25, were within that target. Of the normal axial lengths, again, about 92% within a half a diopter. This is just unparalleled information, and this is with the first data set. Even the axial hyperopes, who are the toughest ones, 85% within the half diopter target. Now, let's compare that with what we've traditionally thought about as the go-to formulae for hyperopes of the last couple decades, and it really outperformed significantly. It's not a close call. So what was my experience after the study? Incorporating the Hill RBF into my regular practice has a lot to do with it. First, we started off with manual data entry, and you've seen this form before. But mid last year, the RBF calculator online became available. And then by autumn of 2016, we actually had the RBF natively installed on the LensStar unit. And that really is a game changer from a workflow perspective, because we have the printouts coming directly out of the unit and giving me all the information that I need. Now, from my workflow, may be different from others in the room, but I always like to obtain the measurements before a consultative discussion with a cataract patient. And in fact, these are the people who obtain this information for me. These are the testing techs at Cincinnati Eye. They're a wonderful group of people. And I just want to call your attention briefly to Mary. Mary is the one who is the second one from the right, and why I'm calling your attention to her will be evident later. So everything always has to start with the patient, right? Everything we do starts and ends with the patient. So once they've gotten their testing, I greet the patient in the room, hi, how are you? And then I look at them at the slit lamp, examine what their eye looks like. We take a look, and I have the LensStar topography, the T-cone topography available to me. I can check for the presence and the regularity of astigmatism. And I really like to look at the Myers as well to see, is this somebody who has some dry eye or perhaps some mapped out fingerprint dystrophy that I might be looking for to catch up on? And then I look at the LensStar printout. If I zoom in a little bit, there's some really interesting information that's very helpful for me talking to the patients before I've had the discussion. One is I know what their axial length is. Why is that important? Well, people with long axial lengths, as we all know, are at greater risk for retina detachment, and it's not always the myope. The axial myopes sometimes have plano or even occasionally hyperopic refractions. So knowing that information might also change how I might select an implant lens style. It's also helpful for me to know what their central corneal thickness is. Maybe they had a borderline pressure, or maybe they got a funny looking nerve. If their corneal thickness, as in this case, is very low, I know that I'm going to have a different estimation of what the accuracy of my applanation tomography was. And of course, once I want to zoom in on selecting the IOL power, I first check and make sure that in fact all of the parameters were in bounds for calculation, and we select what the desired refractive outcome is for this particular patient, in this case a 10 diopter implant. And yes, I actually do pick the IOL myself while in the examining room, studying the topography, the LensStar data, the RBF, and the patient, and that selection is done while I'm in that room. I actually will fill out my surgical plan while I'm in the room, and I still like to use paper for this so that I can see if there's any inadvertent error or change that has occurred from the time that the paper was written and from when I'm in the operating room. And then, of course, we need to take the patient to the operating room, and we need to do a good job on the surgery. This is actually a completely unedited case. I did speed it up a little bit, but we have to make sure that if we're going to do all our great calculations, we still want to do a great surgery. This patient had some iris problems too, and if we're going to think about calculations, we sure do want to make sure that their pupil is in the center, underlying all of the optics which we've carefully planned for. And it's always nice to try and make the pupil look kind of nice too. You can see we're using Ahmed's technique of cautery too. And again, it begins and ends with the patient. Patient ended up with a 20/20 outcome with a minus 0.75 diopter sphere, less than a quarter diopter off of the minus 0.52 prediction that we saw earlier. So Warren mentioned earlier that we all adopt technologies differently. And we all know, or at least we all think we know, where we fall on this list. Perhaps our friends might know better for where we fall on this list. But there's a significant emotional component to this. And we are all creatures of habit, and we should recognize that. So when is it the right time to give up the old method of doing something? Well, we certainly don't want to wait until we're outdated. When we look at the IOL calculation formulae that many are still using today, these are from the 1990s. That's quite a while ago. It's not this millennium anymore. Don't get me wrong, there's lots of good stuff from the 1990s. We had a lot of fun in the 1990s. But there's some stuff from the 1990s that might as well just stay in the 1990s. Remember Mary? This is what Mary looked like when two of these formulas came out, right? So while we are creatures of habit, we're also data-driven physicians. And better data means that it's time to jump and do something different. Can we do repeat personal validation? Sure. It's kind of like going back to our security blanket. There's nothing wrong with double-checking things, right? So I did that in preparation for this meeting. I said, I better make sure that what I'm saying still feels good. So I just quickly took some data from 1 month follow-ups of 51 recent consecutive healthy eyes on a premium IOL platform. Because when is it most important that we're getting these right? Well, certainly the premium IOL patients. Patient that wants to wear glasses because they'd feel naked without them, probably not as critical. Very critical if we're aiming to try and get them as independent from spectacles as possible. So here's the uncorrected acuities from that 50-person group, and we had essentially everybody but one that was 20/30 or better, and the overwhelming majority even better than that. Now do understand, some of these people we were actually aiming for minus a quarter or minus a third. So I'm one of those people, I worry about the outlier, right? I think we learn a lot more from the outliers than we do from the primary individuals. So I went and looked up the data on this one particular patient, and it turns out that she was actually quite happy. She was at 20/25 at her visit before this particular data point was collected, and she was actually within 1/10 of a diopter of her expected target. She did have some dry eye, and I think that that day maybe they didn't ask her to blink before checking her vision, but she was a perfectly happy individual. Whenever we do an internal QI/QA study, it's always worth doing, and I think that addresses the emotional component. But 51 cases is really too small to be statistically meaningful. But it's okay to have an emotional component to things as long as it gets us to the right place. So the things that I think about are, number one, the Hill RBF is objectively superior for IOL power calculation. It just is. It's easy to incorporate into your workflow. And we have an obligation to our patients to stay up to date. And I'd submit to you that we actually have an obligation to ourselves to stay up to date. And better yet, isn't it nice to stay ahead of the curve? The LensStar and the Hill RBF calculator really provide us the tools to do just that. Thanks very much for your attention.